My name's John Beltrame. I'm the Director of Research and a cardiologist at the Central Adelaide Local Health Network, as well as being the Michelle Professor of Medicine and the Head of the Discipline of Medicine at the University of Adelaide. What we do when you arrive in hospital is we put a tube from the wrist into this coronary artery here and inject dye down here to see the blockage. And then what we can do is blow up a balloon here to squash the blockage and leave a little wire cage there called a stent. So then that restores the blood flow here, minimises the heart attack. Part of the problem in doing the procedure is we're putting a metal cage in there and the body says, what's this foreign object, and wants to clot it off. And so we want to use a lot of blood thinners to make sure that doesn't happen, because if it clots off, then you're back to base one, because the artery's blocked off, you're having a heart attack again. So we want to avoid that. And so we're very generous with the amount of blood thinners that we use. And if we know there's a high bleeding risk, certainly reduces other complications as a result of our treatment. The PAMICO project stands for Personalising Acute Myocardial Infarction Care to Improve Outcomes, which translated into English, what that means is individualising patient care to improve the health of the patients when they're in hospital with their acute heart attack. What we're doing different is identifying, which the cardiologists have always known, that some patients are at higher risk than other patients, but here, by looking at the characteristics of the patients, we're able to quantify the actual risk. And so, as I said, firstly, you let the patient know, because when they're signing the consent form, the risk is stated specifically for them. And then also you're letting the cardiologist who's doing the procedure know, so that will influence potentially how much dye they use or how much blood thinner they use to avoid those complications. So the first thing is letting the cardiologist know, so that then they, if this is a patient with high bleeding risk, that they'll use less blood thinners, so it's less likely to have bleeding complications. But I think an important part also is that we need to individualise the care of the patient, so that instead of telling the patient that there's say a 1 in 250 chance of bleeding during this procedure, we've actually individualised it, because in a young person it's going to be a lot less, whereas perhaps an elderly person who's got a lot of other problems, the risk might be higher. So it lets the patient know also, so they can make an informed decision. And so this is part of shared decision making with the patient. And so if we can reduce the complications, we can reduce the readmissions, and everybody wants to be at home and doesn't want to be in hospital.